Hi, this is Yazan Daaboul, live from the American College of Cardiology, ACC 2023, and I'm pleased to be joined by Dr. Dirk Westermann, who just presented the results on the predicting preeclampsia using high-sensitivity troponin. Dr. Westermann, thank you so much for joining us.
Yeah, thanks. Great to be here.
Let's cut to the chase. Tell us a little bit more about preeclampsia, high-sensitivity troponin, how we can connect the two, and let's take it from there.
Yeah, that's a good question, right? Because mostly in a cardiovascular conference, you don't hear too much about preeclampsia, and especially not in regard to high-sensitive troponin. But why did we do that? So preeclampsia is definitely a big problem, especially in the Western world, and roughly 2.2 to 8% of all pregnancies develop preeclampsia, and that's a high risk for the mother as well as the child. And it shares actually some common risks with cardiovascular disease, but that's quite interesting. And so how do you diagnose preeclampsia today, and what are the mechanisms for early prediction? And that's mostly based on clinical factors, and there are a couple of different biomarkers that can be added. But interestingly enough, detection rate, when you follow this clinical prediction path, is not too good. So it's roughly 30% with clinical factors alone. If you add some biomarkers, but not troponin, it's roughly 40%. So that's not good enough. There are some more sensitive biomarkers, especially the biomarker combination or the ratio SFLT1 divided to PLGF. That's published in the New England Journal a couple of years ago in roughly 1,000 patients, done a prospective study. And that could predict preeclampsia quite well in the development code, validation code with an ROC of roughly 85 to 82%. So that's quite okay. But it's costly, not available everywhere.
What is that, or the utility of this marker? Has it been previously used, or how has it been?
Yeah, there's a lot of studies in the preeclampsia field with these biomarkers. They are produced by the placenta, so they are really like from the origin of the problem, and that's why they are relatively specific. But again, they're not approved worldwide, and they are relatively expensive, so they might not be the only solution. And therefore, we wanted to know whether elevated high-sense cardiac troponin, and we utilized a troponin I assay, can predict the development of preeclampsia. What we did, actually, we joined 4 different cohorts of probants, so pregnant women, and we had 4 international cohorts with together 2,293 pregnant women. And those were from the SCOPE, PRINCE, MAVIS, and OCC cohorts, so German, British, and Danish cohorts. And altogether, we had more than 300 blood samples available, and those blood samples were taken at the 14th, 2020, at 22nd and 29th gestational week, so through the period of pregnancy, right? And the interesting part is what we did measure here. We didn't go for the typical biomarkers that are utilized to predict preeclampsia. We used the cardiovascular biomarkers for ACS diagnosis, right? Troponin, and we used the Abbott assay, HSTNI, measured by the architect system. And this is really a high sensitivity assay. So it can quite reliably measure very low concentrations. There are a lot of studies. We published also some studies in the general population, where in the general population, HSTNI can predict cardiovascular mortality over the next couple of years. And the levels, or the median of those measurements, are 2.7 picogram per milliliter. So really very low concentrations that can be picked up reliably by these assays. So what did we do? We defined preeclampsia in those 4 different cohorts, and then looked whether patients had preeclampsia or the severe early onset preeclampsia, and that was defined in our cohort by preeclampsia requiring delivery before the 34th gestational week. And that's a really severe disease, and we want to target those patients. When we go to the subjects, the overall PE prevalence in the whole cohort was 7.8%, and the prevalence of severe early onset PE was roughly 1%. So it's lower, but again, those are the critical patients we need to find. And what we actually could show is that troponins levels are higher in those patients developing preeclampsia beginning from gestational weeks 14 compared to those who do not develop preeclampsia. And that's the same in gestational week 14, 22, or 29. Highly statistically significant, although, and that's important to know, values are obviously not as high as we see in myocardial infarction, but still those can be measured reliably. That's even more pronounced in those patients that will develop severe early onset preeclampsia, so this very difficult form, right? And that's, I think, highly interesting. So then we went to the typical statistic ROC curves to see how troponin measured by the troponin I acid from assay can identify PE, and the AOC was 72% in the week 14, so we could early detect risk for that. It was better at the 22nd gestational week, a little bit less in the 29, but the real strength actually is in predicting severe early onset pregnancy, and those hazard AOCs from over 80% going up to 91% are very interesting for applicating that stuff in the clinic to detect or to identify highest risk population. And when you just look, how could we translate these findings into the clinic today? What are our suggestions to utilize that? And I think the most important part about any biomarkers is actually perfect rule out, right? That's the strength of all biomarkers. And when you look for patients that would develop severe early onset preeclampsia in patients that are in higher risks, the NPV, negative predictive value, of applicating a cutoff that was defined by the statistics is 100%, so really, really high. So we are as good as in ruling out myocardial infarction. And this is quite interesting because this patient group, so that are at increased risk, would normally be treated with aspirin to prevent preeclampsia. And by applying that in the normal cohort, we had a risk of 6.3% of severe early onset PE in those at higher risk. That was defined by the guidelines. And when we then applicated the cutoffs, we could really part this group into two parts. Roughly 40% had 0% risk below the cutoffs, and those above the cohort were only 60% with a way higher risk of around 11%. And those might be, but that needs to be tested in future studies, might be available, the best group for aspirin, because you would have the best risk-benefit ratios because you have a higher or enriched group of patients. And that I could think could be an interesting part. So we concluded that elevated levels of high sensitivity cardiac troponin I precede the development of PE in all weeks we measured. The levels prior to disease development may have considerable potential in grading PE risk in pregnant women. So we can really rule out some of the high-risk groups. I think that's interesting. Obviously, we need randomized clinical trials in doing that. And obviously, this is an exploratory study. It's biased, it's retrospective in its design, as all those cohort studies are. It's not a prospective study that's designed to test that. But we are just going to do that in Germany, actually, to run that prospectively. And I think that's pretty interesting. That's our data, and that's what we just presented.
Dr. Westermann, congratulations on the results. Do you think there's any utility in using troponin as a screening tool for patients with the preeclampsia moving forward?
I think it is. We need to check that prospectively, obviously, before, and I want to be very sure about that, before we can use that knowledge to guide therapy, we need to have prospective studies, right? But I think it's a cheap biomarker. It's available almost everywhere in the world. It's important that our results only apply to the high sensitivity assay from Abbott, so you can't interchange those values with other assays. But you guys know that because a couple of years in the US, the high sensitivity troponins came to you, and it's very important to know the specific cutoffs of each individual assay, right? So you can't just take one cutoff for all assays. That's the same here. And I think it's interesting because it's available, it's cheap, and it might in the future guide therapy.
Dr. Westermann, again, congratulations on the study results, and we're all looking forward to the prospective study. Hopefully, we have more information on high sensitivity troponin and preeclampsia. Once again, congratulations, and thank you all for joining us live from ACC 2023.